Thank you, everyone. And last but by no means least, I hope, for today. So first of all, thank you very much, Luna, for inviting me here. And in doing so, you've prompted me to look back through my research findings with junior doctors and general practitioners, and kind of look at all the evidence around shame and stigma. So first of all, disclaimer, I'm not a shame and stigma research. My research has explored occupational distress, but also the barriers and facilitators to help seeking amongst doctors. And it's through this body of work, over 83 interviews, that shame and stigma came through this entire body of work. So it came indirectly through my research. Yeah, do follow me on Twitter. That's all I'll say. Just very briefly about the study. So first study was with general practitioners. So that was a body of work looking at 47 in-depth interviews with GPs. That was back in 2016, 2017. The second study was a mixed method study looking at working conditions and cultures associated with psychological distress and suicidality. Finally, but my work today doesn't draw on this, but I'm sure it will come out in it because it's very early days. I'm currently running a study which is looking at the impact of NHS, so National Health Service staff, suicide, and its impact on their colleagues and managers and teams. So that's an ongoing study. Very briefly, I wanted to say a little bit about the research team because I feel it's important. I'm a medical sociologist, but most of my research has been conducted with other doctors who have been part of the research team. And that's really important, as well as social scientists. So in the GP study, we had 3 academic general practitioners. We also had a medical student, Anna Taylor. In the junior doctors study, we had 2 academic GPs, 1 academic psychiatrist, 3 junior doctors, because Anna in the previous study, who was a medical school, is now a trainee consultant. Trainee psychiatrist, not quite at consultancy level yet. So quite a mixed team. And they were integral in helping us recruit junior doctors. Just to say a bit about how we kind of frame our research, and we're pretty much all aligned in the team. We feel that the previous literature looking at doctors, a lot of it we felt centered around was adopted a kind of psychocentric approach, which we felt risks pathologizing symptomology, which was a consequence of doctors' working conditions and their cultures. Or related to systemic problems, particularly in the UK around workforce shortages. So we wanted to refocus the gaze, indeed the medical gaze, on looking at the kind of occupational work-related causes of distress, but also the cultures in which doctors work. We are also quite skeptical of the kind of this neoliberal resilience discourse, which perhaps over-focuses on self-care and individual responsibility. And of course, that's problematic with this kind of research because it may detract from solutions which are systemic or maybe connected with cultures such as toxic work cultures. So what do we ask GPs? So we asked them what their sources of distress were. We asked them what the barriers and facilitators were to help seeking for distress or mental ill health. We should say included in that sample were doctors who self-identified as never having been stressed or distressed at all. And we felt it was important to have their views, but invariably, when we interviewed them, there was quite a bit of distress that they recalled in the interviews. We also asked them what it was like to be living and working on a kind of day-to-day basis. When distressed, how did that impact personally on them, but also their relationships with their colleagues and also with patients. Similarly, we asked junior doctors what their working conditions and cultures were like. They often made comparisons between rotations, some which were not so great, some which were more supportive. So it was interesting to have that kind of comparative experience. We asked them how it impacted on them and asked them again what it was like to be living and working, but particularly kind of managing that across different cultures. And again, what were the key barriers and facilitators to help seeking? So data collection, for both studies, we used semi-structured interviews. As I said, for the GP study, we did 47. So this was across England and Wales. Diverse in terms of job role and, status, from GP partner down to, trainee, salaried doctor, that kind of thing. The junior doctors, again, mixed in terms of specialty, years and training, ethnicity. In both studies, the gender split was 70% female, which is really interesting. And again, I think somebody definitely needs to do a study here about why women are taking part in research. And I've got my own, I can kind of guess as to why more women might take part in this kind of research in terms of medics, the population of medics. So with the junior doctor study, it was a mixed method study. We had interviews. So we did 21 interviews, followed by a survey which used validated measures. We used the HSE management standards indicators, which looked at various aspects of working conditions and cultures, job role, support, relationships, work demands. And the outcome measures were the depression, anxiety and stress scale and Pichel's suicidality measure. From the survey, we sampled for those who had opted into the next wave of interviews, those who had self-reported higher levels of distress, because we hadn't captured so many junior doctors in the first wave who had experienced, for example, suicidality, more than suicidal thoughts and feelings. So that was the rationale for including that body. So I'm a qualitative researcher, but I'm just going to give you the key headline findings from the survey because I think they're really interesting. And then I'll provide some of the kind of qualitative data which supports some of the quantitative findings. So both gender and ethnicity were found to have a significant influence on levels of anxiety. We undertook some regression analysis to look at which of those working conditions, so for example, support, relationships, etc., significantly predicted depression and stress. And the two kind of common working conditions or cultures which predicted mental distress, anxiety, depression, were work demands, which I guess is not a surprise for junior doctors, particularly early on in their career, and relationships. So these are the reports from the depression, anxiety, stress scale. So quite high levels of distress, and interestingly, just over half are indicating suicidal ideation. And interestingly, in the qualitative findings for the GP study, we found similar levels of suicidal thoughts and ideation. And again, thinking about kind of stigma, shame in this context, I think this Brown quote is poignant. So she says, shame is an intensely painful feeling or experience of believing that we are flawed and then therefore unworthy of love and belonging. And the other thing she said was, which I find is quite interesting and hugely pertinent to this body of findings, is that she said shame, and it's been talked about a lot today, shame makes people feel isolated, trapped, and powerless. So first of all, let's look at the culture of invulnerability. And this came up a lot in both sets of data amongst GPs across the board, whatever their level of training was, whatever their gender was. It came up considerably in the study. So this is, shame associated with the culture of invulnerability, and the participants were saying it's pretty much enmeshed in the medical identity. So this retired GP, so she retired early because she wanted to, because she'd had enough. She said about the medical profession, yeah, well, you don't get ill, do you? You refuse to accept any illness in yourself, don't you? It's just a question of that's why doctors present late with illnesses, because they don't like to make a fuss. We all see it as a sign of weakness. And she goes on to say it's pretty much drummed into you at medical school, and the end product of that generation, which said basically, if you can't take the heat, get out the kitchen type thing. Interestingly, this quote is from a student who was a personal tutee of mine, and he was talking about this culture, the culture of invulnerability, and he had such an kind of incisive insight into what it was like at medical school. So I encouraged him to document, to diarise, and eventually to write a kind of autoethnographic account of his own insights and thoughts into this. And I think they're really profound, and he has given permission for me to share this with you. And he says, there are certain requirements I accepted when applying to study medicine: a degree of intelligence, passion for the field, and a strong work ethic. If you have these qualities, the course is manageable. However, none of these are beneficial in maintaining a healthy mental state during medical education. Death, physical illness, and even mental ill health are viewed in an academic way. The disembodied approach and detachment from feelings prevents us from engaging with these personal and sensitive aspects of healthcare. Despite multiple lectures and seminars about suicide, terminal cancer, and a host of emotive subjects, not once has the discussion turned to how we, as people, feel about these things. Prioritizing academic education over our emotions is great for getting students through exams, though may not be as effective as preparing them to be doctors. And it goes on to say, acculturating students to detach or dissociate from their emotions, employing unhealthy and unhelpful coping mechanisms during our time at medical school might help to explain why 1 in 4 graduates felt medical school left them unprepared to deal with the physical, emotional, and mental demands of medicine. Offering students the support to be more candid about and connected to their emotions could offer a major step change in helping doctors manage difficult feelings and challenge the stigma that still surrounds mental health in healthcare workers. I mean, what an insight from a student so early on in their career. So, yeah, cultural feeling rules around being invulnerable is, ingrained. It's, they feel it, they hear it. So many of these, I had so many quotes, it was hard to pick which ones to include. But this, so this female doctor says the kind of culture, you're not allowed to be ill, you're not allowed to suffer, and then the stigma attached, and you end up going to work, which is obviously problematic. Presenteeism is problematic amongst doctors. There's an unwritten rule that you don't admit to mental illness in any way in general practice, I think, even though everybody knows that everybody has it, it's just not talked about. And this final quote from a female junior doctor, she says, whatever you're feeling is somehow invalid or invalidated because you just have to grin and bear it and carry on. And I think that kind of degree of performativity around having to grin and bear it is, is divisive in itself. So, yeah, another example of these kind of feeling rules and the culture of invulnerability. I think there's still a lot of stigma, generally speaking. On the whole, medics like to endure and see it as like a badge of honor just to work as hard as you can, to be treated as badly as you can, and to keep going on no matter what, basically. And I think it's kind of interesting because it's almost being stressed or working hard is almost normalized. And at what point is that, that shift from stress to distress suddenly kind of pathologized and then, shamed? And the culture and these feeling rules, I think they further reinforce that culture of invulnerability. It's subsequently internalized. And then you have, doctors saying there's a kind of there's an intolerance of that vulnerability of yourself, but also towards colleagues and your patients. So this, one of the junior doctors says, the number of people I've seen turn up at work with illnesses when they should be at home, they should be in bed, but you've just got to shoulder on because you'd rather be at work than suffer the judgments of other people for not turning up. So there's that kind of risk of feeling or being shamed by your colleagues. And I think to some extent that's exacerbated by workforce shortages, that people feel this kind of compelled, or there's guilt-induced presenteeism to go to work when you're not really well enough. So how is this internalized and how does shame manifest? So this GP, he talks about that kind of internalization process. And so then I'm really struggling, because I'm struggling with my internal dialogue saying, not good enough, could be doing a better job, not really, making people better, persistent negative cycles. Yeah, negative thoughts about yourself. And it's this spiraling in isolation, which is really quite damaging. So, one of the things that surprised me with was the openness about these shaming experiences that doctors were articulating. And this doctor says, and you do feel a huge sense of shame, because even though I treat patients day in, day out with my anxiety and depression, it felt like this was my not coping. And I was thinking, why are the partners all able to cope with this, but not me, and that sort of thing. And I think, and this junior doctor goes on to say, to show that you're struggling is a sign of failure or weakness, and that's really hard to be open about. So there's this kind of constant internalization that it's the individual, it's you that's failing. No one else seems to be failing, everyone else is coping. And again, the kind of isolation with those thoughts and feelings. There were, as was talked about earlier in the work with medical students, work-related sources of shame, whether it was around the fear of making mistakes or the kind of shaming and blaming process involved in, you know, when doctors did make mistakes by their seniors or the consultant. So this doctor says, the fear of making mistakes is huge. When you see really good colleagues who, because you're dealing with such an overwhelming volume of work, making hundreds and hundreds of clinical decisions a day, they're not all going to be right. And this doctor goes on to say, I've had a recent death on a gynae ward, which I found really difficult, partly because I suppose I felt isolated in dealing with that. And that isolation and lack of support accompanying that, and then the consequential kind of blaming and shaming process was often sometimes a tipping point for people going off work long term, or in this case, this doctor made a medical error, resulted in the death of a patient, and she talks about her experience of dealing with that distress because she was unsupported and felt blamed, although she was later vindicated when it went to the coroners. There are all these other things, and ultimately you just think, I feel quite alone, vulnerable, and I'm an F2, so this is foundation year 2 doctor. This was when it really started. I can feel myself getting teary. It's 6 or 7 years later and it's still painful. You then kind of question everything you do, because I just didn't trust the system. I didn't trust my seniors to have my back. You just put on a brave face on, and I think your own mental struggle is no different to anyone else's. So why should you deserve to be in tears in a corridor? Oh, I was in linen cupboards and crying on most shifts. It was awful. And this doctor ended up leaving medicine in the end altogether because of that one incident and the way she was really left unsupported. And feeling, so on the flip side, and we'll see examples of this later, how important feeling supported is in mitigating the impact of doing an incredibly difficult job where mistakes may be made. So this junior doctor, again, kind of visible distress, crying in a corner, but feeling that kind of sense of loneliness with it. You know, is it just her? There were times when one of the nurses would find me crying in a corner, you know, just upset because I didn't know what to do on a night shift or something. I felt unsupported. I think the most painful thing in the early years of being a doctor was feeling like you built yourself up to have this career where you could help people and make people feel better. And suddenly you find yourself in this job where you don't know what you're doing, the pressure is high, and you feel like you're letting people down, you're letting your patients down, and that's the worst thing. So all this has a significant emotional impact, whether it's people leaving medicine, people a trigger for kind of suicidal thoughts, depression, going off sick. The distress is palpable. It was palpable throughout the research. And this doctor, this GP, he said eventually, you know, he'd lost his empathy with his patients. And I think this kind of imagery of him being in a production line, he said he felt like a ketchup bottle in a production line. I don't know why it's doing that. So yes, again, lots of emotional distress. And I remember what I do try and undertake some interviews myself, because there's nothing like doing an interview yourself for that kind of emotional resonance in terms of connecting with your own data. And one GP I interviewed, he was a partner in his practice, and he told me that he would, between patients, 10-minute consultations, if he had much time between patients, he would sit there thinking of ways to kill himself because he couldn't deal with the shame. Lots of suicidal ideation, you know, very distressing to see doctors who are so visibly and palpably distressed and having these suicidal thoughts. And I should say, when most of our participants, when they took part in the study, they were talking about these experiences retrospectively. Many were in a better place, and they were talking about it. They'd moved on to maybe another practice. They sought help, which is a good thing. But of course, it means there may be other doctors still out there who are experiencing a similar amount of distress. It's really important to contrast this. Another paper that came out, the junior doctors study, one looked at the sources of distress, the other looked at protective factors. And in terms of where do we go from here, you know, having support, feeling part of a team, having that kind of sense of belonging, having authentic emotion cultures, all mitigated against the demands of the job. So this junior doctor, she reflects, having been on a toxic work rotation. She says, in the unit I'm in at the moment, it's a lot more about learning rather than blaming. I think you feel safer than to express opinions or to discuss cases. And again, working in an emotionally healthy work culture is different. This doctor says, I feel really emotionally healthy now because I'm in such a supportive culture. But I look now particularly at the name of the specialty culture. Huge amounts of unprocessed trauma. Amazing, really, that the whole profession can be in so denial of the emotional impacts of their job. So just to conclude, before I show you a film based on the junior doctors study, I think invulnerability is ingrained in the medical culture and identity. And I think, as we saw earlier, it starts at medical school. I think shame can exacerbate or contribute to distress. It's incredibly isolating. And above all else, it prevents help seeking. And the research, I think, and the experiences of doctors, particularly on healthy, supportive, working in healthy, supportive work cultures, highlights the importance of safe space, feeling supported, having a sense of belonging, and feeling connected. And I think the NHS needs emotion cultures where staff can make mistakes and learn from them without reprisal, to be vulnerable and to be their authentic selves. And this, I think, comes from having compassionate and empathetic leadership and management. So I did want to reflect some of these findings in relation to major UK incidence reports, which basically say, their recommendations say, actually, that blame and shaming culture is incredibly divisive, and it leads to some of the incidences that we've certainly seen in the UK, probably elsewhere. I penned a model based on the findings. I'd be very interested in your thoughts about this. but I think it just shows the kind of complexity behind what we're dealing with and how shame operates, how it manifests, how people internalize it. I think the cost of performing invulnerability is, it requires emotional work, a la Ali Hochschild. And that's draining, and to perform in ways where we're not our authentic selves is damaging and divisive, and it's stressful. So I'm just going to show you, it's a very short film, and it's me talking about the research findings, but the real star of the show, the real Oscar winner, is Charlotte, who is a trainee anaesthetist, talking about her experiences of seeking help when she needed it. She waived her anonymity to be in the film because she feels quite passionate and wanted to talk out about it. The other person is Anya, who's part of the research team, and she's a junior doctor as well.
You feel unsupported because you are unsupported. You're working in a system that has too few people. My name's Charlotte, and I'm currently a junior doctor specialising in anaesthetics. The commute home, I'm often just quite tired. In the run-up to leaving work, there's the job of finding the appropriate person to hand over to. That's been a real hurdle for me to get over. Feeling responsible for the decisions that other people made about patients that I had perhaps handed over.
The study was interested in looking at working conditions and cultures and their impacts on the mental health of junior doctors working in the NHS.
I would come home maybe from an 11 o'clock or midnight finish. What I knew was going to happen was I was going to get into bed and I was going to try to fall asleep and not going to be able to fall asleep. Or in my dreams, I would be transported straight back to work. I had a discussion with a senior colleague and I just broke down. So this is a blanket that I crocheted whilst I was on sick leave. It was her who made me see that actually I wasn't well. And I kind of didn't believe her because I talked to so many people who felt similar things to me. What I normally like to do to save me from just constantly checking my phone is to do something with my hands, which usually involves something like crocheting.
Junior doctors were telling us that the main causes of stress and distress were around toxic work cultures, poor working conditions, high workload, lack of support, and a culture of invulnerability.
I kind of just thought, well, this is normal and I'm just not coping with it. But then at the back of my mind, I was thinking, if this is normal and everyone goes through this, but this is how I'm reacting, how am I ever going to get through this?
Evidence suggests that doctors who work over 55 hours are twice as likely to develop a mental health problem and are more likely to make a medical error.
My role in the study has been to provide a junior doctor perspective.
The survey reported that 70% of doctors experienced extreme or severely extreme levels of stress, anxiety and depression, and over half of those had experienced suicidal thoughts, feelings. Some had self-harm or had made, sadly, suicide attempts.
I mean, I had a friend who was a doctor and who committed suicide. It was not purely due to work, but there were definitely aspects at work which contributed towards her feelings of anxiety and distress. She was struggling with being very worried about whether she'd done the right thing or made the right decisions, and that can then spill over from work into home and just really make it difficult to leave your work at work.
I much prefer Yorkshire tea. Sometimes the frustration at myself would just get so much, I would just dig my fingernails into my palms.
So the impetus from the study was interested in exploring and understanding why there were slightly elevated rates of suicide amongst female doctors.
It would be naive to suggest there isn't a difference between the ways that male and female junior doctors are treated. I do think that there is more of an expectation when you are a female doctor in the more sort of caring aspects of the job.
Interestingly, 3/4 of the participants in the qualitative study and the survey were female doctors. And again, is that because women are more likely to come forward and, talk about their mental health compared to men, or does it reflect, increased levels of mental illness amongst women?
And I have friends who left the country. The stress on junior doctors will cause there to be fewer junior doctors, and that will result in poorer care. These are a couple of the journals that I started keeping as part of seeking treatment for my mental health. I have had very good support from my own GP, and then also a GP I was able to talk to through the practitioner health programme. I've had support from occupational health.
I think shame is a big issue in medicine, and it starts at medical school, the internalisation of that shame, and that perceived inability to cope. It prevents help seeking.
The NHS is a national kind of government-led system which has a limited budget and limited resources. Then there are significant workforce gaps in the NHS at all kind of professions and all staff at all levels.
In terms of addressing the culture of invulnerability, I think it needs to start at medical school, and there's currently, I think there's an over-focus on individual resilience.
I just hope that everyone in the healthcare system are all able to offer each other some more compassion.
Really important that senior doctors do not lose their compassion that they do have because of the pressures that the system is putting on them.
It's about systemic changes. We all want to help people, but we can't do that at the expense of our own lives.
Do you need your presentation again?
Yes.
Okay.
Okay. So that's basically it. The rest of the slides were references to the study. And I also had some questions for you, actually. I know you may have some for me, but we still haven't really got to the root of why it is female doctors are expressing more distress than their male colleagues. We have some ideas. I'd be very much interested in your thoughts as to why this is happening. In the UK, the rates are slightly elevated amongst female doctors, and it varies in other countries. Yeah, thank you for listening. Happy to take some questions and any comments or thoughts.
So thank you, Ruth, for that important and impactful presentation. So, questions?
And for those of you who are listening remotely, thank you for joining at this late hour in the day. And please post some questions on chat, and I'll be happy to respond to those afterwards if we don't get time today.
So first, thank you for this very insightful and also deeply moving presentation. So what I was struck with was that even in these anonymous and intimate and very personal accounts, it seems that feelings of distress and shame are hinged on being good enough, on making mistakes or not making mistakes. And I was struck by the fact that it seems there isn't even a language for transference. So just being in a room and being responsible in a room where someone is very ill means sort of being exposed to the transference of anxiety, death anxiety, shame, all these things. And it's as though there isn't even a language. So these transferred feelings, there isn't even any way of recognizing them or articulating them. So they sort of feed into something which may not even be their root cause. And that in itself must just be deeply distressing. Yeah, something like that.
Yeah, that's a really great observation. And what happens to those feelings?
Mm-hmm.
And in the clinical encounters, I mean, this is the kind of missing piece of the jigsaw, really. You know, where does this, what impact does it have on the relationship with their patients? Particularly in general practice, it is a very intimate relationship. And it's also, I guess, general practice compared to junior doctors' work. It's a very isolating job working in general practice, and potentially more potential for kind of transference and that kind of thing. Incredibly isolating.
Okay, thanks for a very interesting talk. Lots of great material there. I wonder about the invulnerability culture, if you have any further thoughts about what feeds it, where it comes from. I mean, there seems to be different aspects there. Maybe one could be the kind of authority role of the doctor, and I'm thinking from a patient's point of view. I mean, I'm thinking about, for example, my parents and the way they relate to doctors. The doctor should know what I mean, should be able to provide kind of perfect diagnosis and treatment. I mean, that kind of you come home, you haven't gotten the perfect treatment or something, and it's like this should never happen. And I wonder, I mean, and that has something to do with a kind of, I mean, there's some connection to the kind of scientific self-understanding of doctors there, that error is somehow a deep personal failure, and that if we would have followed you know, some kind of standard norms for scientific procedure, then everything would have gone fine. I mean, I wonder if there is that kind of connection there between how you see your authority connected to a certain ability to do things scientifically. I don't know. Obviously, there are many aspects to this.
It's so complex, isn't it? And, you know, those are important insights. And I think Will's work earlier, you know, around that, you know, the perfectionism, the competitiveness, there's no space, you know, or permission to be vulnerable. You know, I've worked in 3 medical schools. I now no longer work in a medical school, and maybe that's not a coincidence. But they have they have particular environments, and it's very demanding of the self, I think.
Thank you so much. Oh, that's a lot of echo. I just want to reiterate that what an amazing presentation and how sympathetic and sensitive your work is. So thank you for that. I was wondering, in relation to thinking about systems of support and the lack of them at like a systemic level, whether there was another theme kind of underlying a lot of what your doctor participants were explaining, which is that in taking time off, you're also adding to the workload of people that you care about as well. And that because there isn't that systemic support, part of the shame and stigma that people experience is this horror of knowing that you're just like shoving, scare quotes, your work onto someone else who you know might actually also be struggling as well, and that no one is prepared to speak about that. So in failing to have that systemic support, you end up with even more individual responsibility for your teammates, for instance.
It's a real problem, and it's something the participants talk about a lot. There's little give, particularly where, as Anya, the doctor, highlighted, there are shortages in specific specialties. GPs can't get locum cover. So not only, I think the first thought is you're letting everyone down, but I think then to what extent does that shield you're letting yourself down and the shame that comes with that? I think it's both, but in the GP study, a lot of them talked about that guilt associated with taking time off work. And we know that when, generally when doctors do take time off work for distress or mental ill health or for burnout, the recovery period is a lot longer. And then there are some people who don't come back.
Thank you very much. I was just wondering two things really. One is follows up on the question before last. And I was thinking about how training, one of my best friends, his sister works in CID, investigating sex crimes, particularly against children. And she often says to him, you wouldn't, you couldn't deal with what I have to witness on a weekly basis. And you have to be a certain sort of person in order to do this job. And often in the police force, people get rotated in and out because people can't deal with it. And I think if someone working as a police officer can feel that, imagine, there are doctors in this room, for most of us, for those of us that haven't had medical training and haven't been in a hospital setting, I think it's very difficult to even comprehend, what you have to do in order to be able to work through what you're seeing. They're not the sorts of things you see. And you're seeing people who are very poorly every day. You're seeing people who are dying. So I think one thing we have to take into account is that how the profession demands that you don't have the kind of empathy and emotional vulnerability that we have. And this in part might be a side effect of that. And so then the question is, how do we address that side effect while still allowing that professional training that is clearly required? That was one thing. And the other point, which is not really related, but I thought the other thing is maybe we also should hear from those people, because there are people out there in the NHS, in the workforce, who think that this is the right way to be. And, so maybe it would be good to get some, I'm not saying that I agree with them. I'm just saying it would be good to get some insight, to hear their rationale for why they would say these people are weak, rather than, we all agree with these people, the people on your film and the people you quoted, they're very powerful quotes. But it would be interesting to hear the rationale for those who take this very hard line and say, well, stuff and nonsense, this is how it's got to be.
Deal with it.
Yeah.
Get out the kitchen. Well, I did a presentation on this study recently at the International Practitioner Health conference in London. and there was a junior doctor there who said, you know, they need to stop telling us those kind of things because it doesn't help us. We don't want to hear it. And actually, it hasn't got easier. It has got worse because patient demand has gone through the roof, and we're dealing with workforce shortages. But all they're hearing is, you know, in my day, blah, 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 blah. And that's simply not helpful. And what was your first point briefly? That was
the point about the, you know, when you're training somebody to be a doctor, the experiences they have. I mean, those of us that have never had medical training and never been in a medical context could hardly imagine what you have to witness and be exposed to. And they aren't just witnessing it, they have to carry on and keep doing their job through it. So there's a sense in which there's built into the training is the ability to have some emotional distance.
Yeah, I think, look back at what that medical student was saying, the curriculum is whitewashed of emotion. They've stripped emotionality out of the curriculum. So maybe they need people like him to write the GMC curriculum, because when you say to medical schools, why don't you do X, Y, and Z, balance groups, torch rounds, you know, all the things that we know, you know, can help and kind of set that positive, you know, open, authentic emotion culture. They say there's not space on the curriculum.
Yeah, I've got two friends who are bioethicists that went and worked in medical schools as bioethicists, and they both reported the same experience. One was in Australia, one was in Norwich, and they both reported the same experience, that by and large, the students were unreceptive to this kind of thing when they were trying to teach it. So they had all on persuading the students that they should have any interest in things like emotional responses and ethical considerations. It was a profession, it was a science, it was medical science, and they didn't want to hear what an ethicist had to say.
Yeah, and I think often they put on one-off, you know, I mean, either it's resilience training, it's again, gaze back on the individual, or, you know, an optional mindfulness session.
Well,
I mean, nothing against mindfulness. I practice it myself.
Yeah, this sounds strange to me, because it sounds like things are getting worse rather than better in medical schools. Is that the experience of people who have, I don't know, Des, have you got a sense? Do you want? Oh, Barry, forgive me. Because that wasn't my experience when I was doing this 7 years ago. It was getting better.
I think it varies from medical to medical school. I think there's a lot of variation from what I'm hearing.
I don't know whether it's got worse or not, but I suppose I just want to come back to an earlier point, which is about gender. So one of the things that I've done for the best part of 10 years is run debriefing sessions in our intensive care unit after deaths or deaths in theatre. And it's a mixed group, so we would have nurses, other healthcare professionals, and doctors who would attend, but we have a very sparse male attendance, to almost nil, and that's quite interesting. And that makes it say something about me as somebody who runs the session, or it may be maybe something different. But it is when you speak to sort of male doctors who have been part of something that's really quite emotionally harrowing, they really don't want to talk about it. And so, you know, without falling into sort of gendered stereotypes, there is something there. And we've had 2 suicides in a relatively short space of time, both males. And well, one would have thought that might have precipitated something different, but it hasn't. But we've had an increased female attendance even as a consequence of that. So there's been this significant response to it, but it's actually been a female response to 2 male suicides. There is something significant there, but I don't know exactly what it is.
Could be the way men are acculturated.
It just seems a very simple sort of thing, doesn't it? Just to say it's just men.
Not all men.
Not all men. I suppose just to go back to medical schools, I mean, I teach this in a medical school. I teach trainee doctors. In fact, I've used quite a lot of your quotes in my teaching. So I'm familiar with it, and it does get quite a response. I mean, I think every junior doctor that I've shown those quotes to recognizes them. They're not unfamiliar, they are their lived experience. So there is certainly an appetite or an understanding, but there's no real space for solutions. I think that's the problem, that when you go from the classroom to the clinical environment, there's a substantial gap there, and it's a gap we haven't bridged in any really meaningful way. Sorry, that's a comment. It's kind of a question. I suppose I'm interested in your, I suppose you've done this for a long time, and in what you perceive solutions to look like.
I think they've identified many of their own solutions. I mean, that insight from the medical student, I was gobsmacked. And also the fact that he was male as well, you know, that he gave himself permission to talk openly about that, because he was really struggling with that. Maybe he was an anomaly. And the solutions have been mooted time and time again about the importance of teamwork, you know, authentic emotion cultures, compassionate leadership. And I think there's something about when the systems are under huge pressure, and there's something about that space, isn't there, that maybe we don't have. But I guess it's not all doom and gloom, because there were examples of amazing work cultures, you know, no added resource in terms of money, but just that compassion towards each other, so it can work. How you roll that out across, you know, the biggest employer in Europe, you know, yeah, it's a lifetime's work for me. Yeah. Last question.
Yeah, just a final comment. I mean, the interesting point about the kind of different cultures within medical schools, and I wonder if it's in some ways tied in with the size. Birmingham, I understand, has got a very large cohort of students. Our cohort in Durham, when we still had a medical school, was only 100, and there was a real very strong personal relationship between the staff and the students. There was a very supportive environment. We knew the students well, that kind of thing, and there was a real sense of that sort of personal engagement. And I think it's increasingly the case as more and more people are being recruited, try to address these workforce pressures, that people are, I mean, I examined on a huge medical school in London, and I didn't really understand how they got to know the students at all, actually. So that was one thing. The other issue was just about your kind of the gender balance in terms of responses to this. But have you cut it by ethnicity, which is another significant element, and wondering how that works out?
In what respect, in terms of how the findings play out?
Well, no, to the extent to which people of different ethnicities or different are you know, engaged with your process. You know, we've got the female male kind of difference. I mean, is there also a difference across different ethnicities? Because there's a huge, I mean, the influx into medical schools, a huge sort of Asian contingent, for example. You know, I wondered to what extent there were any differences in relation to that.
Well, gender and ethnicity were predictors of higher levels of distress in the survey. And also we're just undertaking some secondary analysis on the intersection of gender and race-based discrimination experienced by junior doctors, which is an issue. And that's been undertaken by a medical student who I'm supervising, who self-defines as a woman of colour. So it was important to select somebody with a, you know, woman of colour ethnicity to undertake the secondary analysis, because our team is very white. Yeah, thank you for your questions and your comments.